So I'm George Brenner, and I'm a licensed clinical social worker, licensed marriage and family therapist, and licensed clinical addictions counselor. Live and work, except when virtually, in Indianapolis, Indiana. And I've been in the doing this some area of clinical work for going on 50 years now. And the last 10 years before I retired, was working primarily as part of a psychiatric social work team that did medical bed consults. And as part of that, certainly had an interest in integration of mental health in primary care services, as people oftentimes ended up, and would do consults in the emergency department, et cetera. I've also been a member of MINT now over 10 years, and so have a real interest in training folks in motivational interviewing. So that's just a quick, brief introduction. I hope that's okay, Stephen. A little bit about what we're going to talk about today is a little over 3 years ago, I was contacted by IU School of Medicine, the emergency department, emergency medicine. And they were getting ready to do a study regarding low-risk chest pain and its relationship to folks who actually, the primary issue was anxiety. And they showed up in the emergency department, and it was not related to cardiac event, but it was related to anxiety. And they invited me to be a motivational interviewing consultant to this research. So much of the protocol had been written, although the desire or how MI was going to be integrated was not. And so that was my role in this study. The study is ongoing, by the way, and for a variety of reasons. But what I wanted to share today, and I hope people, I'm used to having conversations with folks, and so I would encourage people, if people have questions or want to ask questions as we go along, I'll do my best to address those. So I'm going to go to my PowerPoint and kind of talk about what's how we did that, what it is that we did. I'm going to start this by prefacing that what Bill Miller said, and I've heard him say this a couple of times, and most recently at the forum in Chicago this last fall, that most of the research involving motivational interviewing will probably never show up as motivational interviewing research. That it can be integrated with, and that much of the research today is on the integration of MI with other approaches. And I think this is probably one such study. So what I'm going to talk about, because this will probably never show up in the annals of MI, it might show up as a citation. The study is patient-centered treatment of low-risk chest pain in the emergency room. And this presentation is about what we did to integrate MI into the PACER study. As a point of reference, because this is an ongoing study, because of the novel elements and the uniqueness of this study, it was recently published in Contemporary Clinical Trials, volume 124, and just published this month. This is the actual title of the study. If you would want to see the study, so this is really about the protocol, not the results. As I said, the study is ongoing, so we do not have the results of the study, and the results will not show the impact that MI had on its on the study. but you're welcome to access this. I will make these PowerPoints available to you. There's nothing proprietary about them. And at least this article's available to you free of charge until January the 17th with my personal author connection. I want to acknowledge the folks who were involved in this study. Most of them are faculty at the IU School of Medicine. A representative of NAMI, National Alliance of the Mentally Ill, which was responsible for providing the peer coaches that I'll talk about briefly in one element of this study. There was a patient advisory committee that played a key role not only in helping me, also to help the guide and the materials in the study. St. Vincent's Hospital in Sydney, Australia, as part of the peer coaching in one of the areas of study, is a self-help manual online and called This Way Up. And Michael Millard was responsible for that. And then I, as a consultant in our company, Continuing the Care. I want to acknowledge a colleague, for some of you who are members may know this person, Mallory DeSalle at IU School of Public Health. She was not an author on this study, but she was a consultant to me as she has been responsible for the rollout and is a primary training for expert in the state of Indiana, primarily on primary care integration of screening and brief intervention for referral for treatment for substance use disorders. So she has a lot of experience integrating and rolling out expert design programs. So why motivational interviewing? Because there was concern about this from the very beginning as they were designing, and to use the language of motivational interviewing I'll use their language that they used that is in the article, which is that the journal, which is they wanted to incorporate it for engagement and enrollment. And so we translate that usually in motivational interviewing into to address the common problem of ambivalence. And ambivalence occurred on many levels in consideration for this study. One is the ambivalence about people showing up in an emergency department thinking their chest pain is significant enough to go to emergency department, and that whole sense of being told, it's not a cardiac event, it's low risk, and it might be anxiety. So people are ambivalent about, gee, this was physical, it felt physical, and they're telling me that it's something else. And these are not my words. This is kind of from what patients or clients describe. Also ambivalence about, can I do something about this? And part of the study is to really help people realize that if they accept that it might be an anxiety, that there's something they can do. And then another type of ambivalence is, do I want to be involved in research? And this ambivalence occurs on many levels. One is the ethical consideration, since this is a human subject research, is that enrollment is always voluntary, and paying attention to that when we talk to people that their enrollment is in fact voluntary, and being again, using the concepts of MI counseling with neutrality. The other thing about this is that from their data, a large percentage of folks were persons of color, particularly African Americans, whose experience in the emergency department was not necessarily a pleasant one. They experienced some of the healthcare disparities. And while not all of the patient partners that I interviewed, and I'll talk about those a little bit more soon, most of the patient partners were who had experience in the emergency department and come to terms with the fact that it was related to anxiety. Most of them either were familiar by name to the Tuskegee study, or that discrimination happens in research, and that it might be. And mind you, this rolled out prior to COVID, so we're not even there yet in terms of people's reluctance, in terms of what is the medical crisis, etc. The other thing is the why motivational interviewing, to manage some discord. The emergency department sometimes can be a rather unique experience for folks. And I remember this from my emergency consult days, is that if it was a mental health situation, frequently the goal was to get them out of the ED and work with real problems. And also that people, the patient partners told me that sometimes the insinuation that it's in your head, or thinking that you're crazy. And again, we know the stigma. So the patient partners helped us understand the nature of discord as it might be experienced in the emergency department, which is that relationship between the caregivers and me as the patient. Why motivational interviewing? There's a long history of MI with expert in screening for problems, particularly related to substance use disorders, and trying to figure out how we can adapt the expert model to anxiety, particularly not from just having people come to terms with it, but maybe doing something about it. And getting the goal of the study is trying to effectively intervene with low risk chest pain, so that person is not back in the emergency department in the future if it's related to anxiety.
I need to talk because my computer is. Oops.
Hello. Okay. And we know, Stephen, the long history of MI with the using motivational interviewing in primary care. The fact that it's a patient-centered approach was very attractive to the folks, again, because they were concerned about healthcare disparities. They were concerned about customer satisfaction or patient satisfaction, and that MI is a patient-centered approach and might help with resolving ambivalence about being involved in doing something about their anxiety. Also, that MI, because part of the goal of the intervention, the initial enrollment, was to provide a little patient education that it could be anxiety, as a way of having the person focus that maybe it is something else. And so advice with permission is an effective way of providing patient education. MI pays attention to the language. And so one of the elements even discussed in the article is reducing jargon and stigma as we worked with patients in the ED, or working with patients in the ED. The other thing is that two of the three interventions, if the person enrolled in the research, two of the three interventions were CBT. So, and maybe I should just take a moment and talk a little bit about the three elements. So the overview of the study is the goal was to enroll people in the study. It was a non-medicine, so it's not medication, and that's emphasized in the enrollment process, so that people, again, as we found with COVID, it's probably a good thing that we emphasize that they weren't being, it wasn't about an experimental drug. For those of you who are on the forefront with vaccine hesitancy and resistance. So the goal was, once enrolled, if the person's willing to accept that it might be anxiety, there are three different interventions, and they were going to measure the benefit of those interventions in reducing, getting people to care, and also then reducing readmissions to the emergency department. Those 3 interventions, once enrolled, as people were randomly assigned to one of 3 groups, which is an enhanced referral to a primary care physician. The second was a referral to the self-help online, along with peer coaching. And the third one, intervention, was and the online intervention in peer coaching is a CBT approach, cognitive behavioral therapy approach, as well as the third intervention was with doctoral candidates in psychology using a CBT approach as well. So those were the 3 random assigned. Any questions up to this point as to why MI or where it might fit into this kind of research? If not, I'll go back to sharing screen. So let's talk about what happened or how we integrated MI in the screening and enrollment process. Within the SBIRT model in the literature, you'll find what are sometimes called scripts, and they kind of are, you can't script an intervention. So we didn't call it a script, we called it a guided conversation or a guide. And what we did is looked at the literature and said, could we adapt this to a guided conversation regarding screening and then potential enrollment into the SBIRT process for anxiety. Patient partners were very much involved with this. One of the things that I did with the patient partners is interview them related to their experience in their experience when they went to the emergency department and were told that it was not a cardiac event and it was probably anxiety. I interviewed them regarding language that would reduce stigma and be less jargon oriented. In other words, away from a diagnosis and using words that would describe their experience. And again, with the goal that it might increase acceptance that it could be anxiety. And we looked at language that addressed cultural and racial disparities. What's the language that they use to describe their experience with anxiety? This helped us construct the conversation or the guide to reduce, for those who had a pretty negative, many of them had pretty negative experiences in the emergency department. They didn't feel it was personal. Their concerns didn't feel addressed. They were essentially told what it wasn't, not what it was. And so we kind of looked at how do we create this guided conversation in such a way to address these concerns. Once we did that, I had these meetings with patient partners. At least 3 patient partners were willing to, we recorded sessions, and these recorded sessions were also used then for teaching purposes for the enrollment professionals. The recorded sessions were with the patient partners as if I were interviewing them for enrollment into the process, and then asking them for feedback about the language, how they felt, the connection, the relationship, etc. And then there was motivational interviewing training for the enrollment professionals. And then we did coaching. I also thought about the literature on the guide and constructed the guide paying attention to the 4 processes. How do we invite people into a conversation? How do we engage people? How do we let them kind of know up front what this conversation is going to be about? The focus process involved the screening. And this was what we tried to do there with coaching was fairly critical. A lot of the times the personnel were technicians, though they were not behavioral health folks who are used to interviews. And so what we tried to do is construct it without losing fidelity. By the way, the screening tool was the GAD-7. And we tried to use the screening tool in such a way that it made it more conversation than less like a question and answer or procedure. And this has been a major element of coaching is how do you offer a screening tool that doesn't just seem like a question and answer checking boxes. And so thinking about how do we use reflections? How do we emphasize? How do we pace it so that people give it some thought as the screening tool was administered through a conversation, not through a pencil and paper or electronic means. The guide was also constructed with attention to autonomy and equipoise. As I said before, because this is a human, this is a clinical trial with human subjects, enrollment, we had to pay attention to autonomy, and that enrollment is completely voluntary. So for ethical reasons. At the same time, we did pay attention in coaching to that there's a difference between reluctance and what is I sometimes refer to in coaching as the hard no. Sometimes working with folks who were kind of new to this work is that if people were reluctant, they were hesitant to move forward in the conversation. And so reluctance and reluctance on the patient part sometimes seemed like a no, and we were able to kind of coach that there's a difference between no and when people are still ambivalent about, gee, could this be anxiety? And then again, the coaching, because these folks had not been involved were not enrolled subjects at this point, we could not record patient sessions. And so as in the other two arms that I coached and we integrated MI, the coaching involved role play and supporting MI integration and talking about what are sometimes referred in the language as helpful responses. We also had to learn to adapt because initially the screening or the guided conversation was to be conducted in the emergency department. And the study was developed prior to the COVID pandemic. And so we had to we had to move to a situation where people weren't necessarily coming into the emergency room at the same numbers with low-dose chest pain, that the conditions for those of you who are working in emergency departments know that things change during that time. Also, this then didn't go from a warm handoff to a technician in the emergency department, which was the original design. It really became much more people were discharged and were contacted after they left the emergency department. Also, Indiana University has multiple emergency departments at multiple hospitals. And so the study was opened up to multiple locations. So we had to really kind of coach about how to do this work remotely, either telephonically or through Zoom connections. So a lot of work, again, went into this, and the patient partners were incredibly important in this whole process to think about how we could use motivational interviewing to resolve some of the ambivalence about seeing this as anxiety and not, in other words, to accept that their physical discomforts, their symptoms were real. They were just not explained by a cardiac event. And if you, to try and stay in my lane, if you want to look at some of the criteria for who were candidates for this subject, I would refer you back to the article and the protocol there in terms of how it was determined that these were low risk chest pain and that the study, that they were appropriate for the study. Arm 2 and Arm 3. So once enrolled, then a person, as I said, would be randomly assigned to one of 3 groups. An enhanced referral, and if people, because of the locations of some of the emergency departments, some of these folks, or many of these folks, did not have a primary care physician to follow up. And so there are efforts in Arm 1 to connect people and making sure the information got to the primary care location where they might follow up with care. And so that the results of the GAD-7, by the way, and I didn't mention this, I focused primarily on the GAD-7. It was also added that panic would be, after this started, persons were also screened for panic. So it's a positive score on the GAD-7 and a positive panic score and a low risk chest pain. So what did we do in Arm 2? Arm 2 is peer-guided CBT. So folks in Arm 2 go online and they do a self-studied lessons. I want to say there are 8 lessons if they also experience panic. And what we did for the folk, and then what they do is have weekly phone calls with a peer-guided coach. And peer guides, as the title suggests, are folks who've had experiences with anxiety themselves and who have some type of support to manage their anxiety. And they are folks who've gone through peer coaching training and are certified, in most cases, certified peer coaches. And so again, that sense of coaching as opposed to telling. So what we did in Arm 2 is train people in motivational interviewing. Now, one of the major elements that I was involved with then was developing, because we are evaluating fidelity of MI integration. And I really want to say integration. Since it's integrated effort and not MI, the tool that we selected for this study occurs in the literature on SBIRT called the MI Spirit Scale. And it's 6 items. And if you want to know which one we use, I can certainly provide that to you as well. Because there are 3 common ones that I discovered for using an SBIRT model. The problem with the parameters are: the practitioner solicits the patient's own reasons to achieve target behavior. The practitioner summarizes patient's stated reasons for change, treats the person with respect, negotiates a plan that's collaborative, affirms the person's strengths, ideas, and successes, and the practitioner talks less than the patient. And so what we found, though, so so we didn't use a MIghty or MESA. So we picked this because it's primarily designed for an integration, or it's useful for an integration of MI in an SBIRT intervention. So it's really not just about being competent in MI. And that was particularly useful here because the primary focus of these of the modules are cognitive behavioral therapy and self-regulation, self-management. And so it really is an integration. Now, what we did too then is try to say, well, one of the things I found that seems somewhat missing in the literature on the spirit of MI is that they weren't benchmarked. And so one of the things that I attempted to do was to benchmark on a 1 to 5 scale. And I did adjust that because sometimes some of the elements aren't always applicable. And so I did do some adjustment. And I tried to benchmark, how do we account for the micro skills being present in the session? In other words, one way of summarizing the patient's concerns or reasons for change really sort of imply the micro skill of reflections. And so what I tried to do is benchmark. And so I'm using 2 scales. One, the fidelity, the spirit of MI fidelity scale, benchmark with a basic ORS coding with some emphasis on, when I hear reflections, not just that the person reflects just everything the person they say, or reflects a sustained talk in the same way they reflect change talk. And so these are benchmarked. And so when people receive feedback, they are essentially coded, and the feedback comes from a general coding on the spirit and ORS score. The sessions are recorded, and so we randomly select patient sessions and code for the spirit of MI fidelity, and then try and coach people. One of the real challenges in all 3, both with enrollment, the CBT, rather ARM 2 and ARM 3, has been turnover. This study has been going on now for several years, and there are new psychologists interns based on the semester or year. And there's a fairly significant turnover in enrollment staff as well as peer. And so we're always kind of playing catch up and retraining folks. With ARM 3, this is the therapist guided CBT, so it's not manualized. Again, we use the same approach to fidelity, which is, first training, and the training in MI isn't all done by me in this arm. A lot of the folks have been trained in graduate school, have had exposure to motivational interviewing, and so this really enhances their knowledge, the training that I provide and coaching that I provide. The fidelity tool is the same fidelity tool, which is the spirit of MI, and again, benchmarked according to the level of use of open-ended questions, affirmations, reflections, summaries, and advice only with permission. And that was actually in both ARM 2 and 3. That has been a major emphasis in coding, is that people see themselves as teachers, not always listeners. And one of the challenges sometimes is getting people to use the ask, provide, ask approach to client education, and avoiding what is frequently referred in the MI world as the expert trap. Again, what we do is we randomly select sessions, listen to a portion, a work sample. I code that, and then we do offer feedback and then coaching that will enhance the person's skills. So that's a pretty quick overview of what we did in this study. As I said, in the article is really about the protocol. I can't really share with you the results that we received up to this date. I think the expected completion is at the end of this year. This is my contact information if you want the slides or you have a specific question about what we did that I'm able to answer. understanding the limited role that I have and that the fact that the study is ongoing. My email is backbren90@gmail.com. So, any questions, thoughts about what we did?
Hi, George. This is Sean Jeffries from Texas. I really appreciated your presentation. I had a quick question for you just on the methodology.
Yeah.
You said the GAD-7?
Yes.
I'm not familiar with that one. Could you? I came in a little bit late. Could you describe that question?
Yes. Yeah. Kirk Cronky, one of the researchers, very much involved in the GAD-7 development and research. I have it in front of me. It's readily accessible. And basically, oh, I had it. I thought I had it here. I have too many papers in front of me, Sean.
Looks like Stephen.
Here it is.
On the screen.
Yeah. Okay. There it is. Yeah, I have it. I found it. And so basically, it's over the last 2 weeks. How often have you felt this way? Felt nervous, anxious, or on edge? And again, it's a 0 to 3. There are the ranges then. The ranges on this, and the cutoff that was picked for this study was a score of 8. But basically, see if I can find it. So a 0 to 4 would be minimal anxiety, 5 to 9 would be mild anxiety, and 10 to 14 would be moderate anxiety.
Okay, so it's not a diagnostic tool for GAD per se. It
No.
just has those. Okay.
Correct.
And then the panic criteria you said was.
I did not have that in front of me. It's okay. in the study. It's in the study. It's again much like this. It's not a diagnostic tool. And this is an aside, kind of anticipating a question you might have not asked. Is that in working with the psychologist residents, even though they're referred for generalized anxiety, a lot of times people will then get to the psychologists who have training and diagnosis and then sort of find the problems with screening tools, much like with SBIRT for substance use, is that it screens for inappropriate use of substances, but is not a diagnostic tool. And so people with advanced skills in diagnosis sometimes find that less than adequate, if that sort of anticipates your question, John.
Yeah, that was it. And I just wanted to say thanks for a very good presentation. So thank you for sharing that.
Yeah, Sean. Thanks.
Let me jump in for, I just want to quickly say, and I have many questions, but are not comments, and a lovely summary, really quite extraordinary. So congratulations and thank you.
Mm-hmm.
It was very impressive. I just want to jump in on that GAD-7. I'm glad that you asked the question, Sean, because as somebody who's worked in primary care interface and medicine for 40, 50 years, I know this work well, and the history of the GAD-7, and I applaud its use. And I just want to encourage it to be even more and more widely used. Since Kirk Cronky, one of your collaborators, and actually these were developed in industry by Pfizer with Bob Spitzer, who was the father of DSM-3, involved in this collaborative effort in the 1980s. They worked on what's an instrument for depression called the PHQ-9 and GAD-7, and those two have through 30, 40 years just shown just incredible strength as both screening tools and have certain predictive validities towards predicting diagnoses. So while a highly skilled clinician may often consider themselves better than the tool, there's been quite a bit of research that shows it's not necessarily a lot better, and it usually can be a good tool in addition to clinical work. So anyway, I want to just quickly applaud and encourage its more widespread use.
Yeah, according to at least the data that I have, for GAD, it has a sensitivity and specificity of greater than 80%. So again,
Exactly.
as you said, Stephen, it's a fairly reliable tool when it doesn't always pick up on some of the more nuanced types of anxiety disorders or additional things. But anyway, yeah.
Yeah, absolutely. So again, lovely talk. I don't want to dominate it all, so I want to. We have another 15 minutes.
Yeah, and Celeste, I think you had a request. Just send. I think was it you, Celeste, who had wanted to know if you could get the guide.
Yeah, thank you for your great presentation. It was really helpful, especially in hearing some of the similarities and enhancements that I've done similar type of research. And I find that first initial, quote unquote, you called it the guided conversation,
right,
is really important. And I'm just wondering if, your study is still happening, so I'm not sure if you can share that. But typically, how long does the guided conversation last, and what are some key components that you may be able to share?
Yeah, so I can probably ask the primary researchers if I can share the guided conversation with you. So what are the key components? So again, back to the whole sense of trying to kind of conceptualize in motivational interviewing terms, the 4 processes or 4 stages, which is paying attention in the engagement process. Is that introduction, the emphasis in this case that it's a voluntary study, emphasis when needed that it's not a medication, because that's a kind of avoiding, and these are specific to this because of the medication experimental drug hesitancy with persons of color in this case. So really just kind of helping people and then inviting them into a focused conversation. So one of the things really paying attention to, how do we open the conversation that engages people into being willing to talk to us further? Again, the focus process really is the screening tool. That's the focus of this conversation, is trying to think, well, what's it going to be about? Well, it's going to be about anxiety, and having people think about, we've all been to the doctor's office, and I've been involved with previous expert with substance use, and trying to get away from this seeing as a checkbox or just a procedure and making it more personal. How do we use a screening tool to sound like a procedure, or rather a conversation? And so, and at the same time, Stephen, hold the fidelity, in other words, not lose the validity of the tool. And so just having people, Celeste, slow the conversation down, giving people a moment to think about it. And then when people answer, if they answer in such a way that it indicates that it's frequently a problem, or at least half the time, really coaching people to reflect that back. So what you're telling me is that half your days you have excessive worry. And so it really gets people anchored. And our concern is that a lot of folks who experience trauma or worry sometimes have normalized this, and it's just part of their life. And that's what I heard a lot from patient partners. It's like they hadn't really thought about that it's unusual. They just think this is what life is like, and you live in poverty and and struggling sometimes. And so so that whole sense of, so that's the focusing. And then really thinking about what do we do that is evocative in a screening process. And so after we give the results, we people are coached into talking about doing a scaling on a 0 to 10 scale. How important would it be for you to do something about that? And then and doing a little advice with permission, in this case, education with permission, asking what they already know about anxiety and what they think about the results of and then in the evocation process, also kind of thinking about there's a long list of open-ended questions that might get the person to think more about it, having a deeper dive in their own mind about what do you see the benefits, say examples, or what do you see the benefits of managing your anxiety? How has the anxiety affected your energy and sleep? So kind of also going back to those questions. And then the summary is the summary then is the enrollment conversation. Are you interested in signing up? In testing with this with the guided conversation, excluding the enrollment conversation, because obviously there's a lot of paperwork that is involved in there. I found that typical amount of time for me, and I'm kind of, I have a therapy brain here, not a screening brain or a diagnostic brain. I would generally could get through it in about 20 minutes. And in coaching the enrollment people, they were able to do this in a similar kind of time frame. Does that answer your question?
Yeah, it really does. And I really appreciate you being explicit with those steps, with the focusing, the evoking, and then the summary, and just giving some small examples of how you did that. I think that's really important, and going forward for researchers to consider, embedding the kind of work, the invitation and that first meeting in that way. So yeah, rather than just check.
Yeah, and we found that really important as we tried to figure out how to, because most of this is now done virtually. It was intended to be in person where you can make that connection easier. We've worked a lot on how do we do this virtually with
thank
people.
you.
Yeah. Other questions or thoughts or comments?
I have a comment and a question.
Sure.
Was just waiting for other people to jump in, but I'll go ahead. The comment, firstly, I was thinking of the way we've thought of these sessions as MI stories, and it wasn't my idea, so I can compliment the framing of it as solutions sought and lessons learned. And so I was thinking during some of our other presentations, in particular this one, how in fact how generative, I guess, this presentation was along those lines. I think this very interesting group of clinicians came to you and sought solutions for a lot of issues. And I'm thinking that each one of your PowerPoints is about questions about what's the solution for education, what's the solution for enrollment. And, I think perhaps many, if not all of those, say 40 bullet points are the solutions that you've offered. And of course, and your suggestion that they're lessons learned, and I think we're all learning lessons. And in fact, this is a nice empirical test of the solutions you're proposing, because we may have or will have outcome data that will shed light on each of so many solutions to perhaps 15 or 20 important questions that the research has asked you. So I just wanted to frame it in terms of the language of these sessions, in terms of the way my mind is working now. But, just a great job, I think, in channeling those difficult solutions and towards lessons that will be learned.
Mhm.
So
Thanks.
thank you.
Mhm.
So my question was, that was a long
Yeah.
comment. My question was your validity tool, your fidelity tool, and you
Uh-huh.
mentioned that you're not using the Mighty. I don't know a lot of the other tools, and I'm interested in looking at yours if it can be shared, because we're doing work in our own area and we're using the Mighty because we like it
Mhm.
so much. Why did you feel the need to develop your own tool, and what does your tool do better for this purpose than the Mighty?
Probably a good question. I don't know that I have a great answer. And part of it's just my preference. In working with people who are not therapist types, I have long found, back to the early days of MI, a good ORS coding. If we're working people on developing basic skills in motivational interviewing, is just really kind of listening to the kinds of questions, open questions they ask, reflections. How do they reflect the change talk as opposed to just saying, kind of reflecting everything? Kind of back to the old helpful responses. Am I noticing affirmations? Are people really acknowledging people's efforts and strengths and what they're, and so I have found that with people who are not necessarily, and again, because I'm really, this isn't an MI study, so I'm not necessarily interested, and maybe this is me, I'm not necessarily interested in could they pass, are they specifically competent in MI? Are they proficient in MI? What I'm looking for is helpful responses. And I think that's the literature about, and sort of that resonates with me, is how do we get people to have more helpful responses? Now, I didn't really recreate a fidelity tool, Stephen. There is, the Spirit of MI is an accepted fidelity tool for ESPER. What I tried to do to make the coding and coaching, or feedback and coaching, more helpful is benchmark what I couldn't find in the literature, because the six parameters that I found, and you'll find them. I found them when I was trying to develop this tool more, so I could use it more purposefully, and that it have some, because I'm not doing all the coding for the fidelity. What I didn't find is that they were benchmark. And so how would we benchmark? How would I know, or how would we have multiple raters saying the practitioner always treats the person with respect? Now, I was thinking, well, how do you do a 1 to 5 scale on that? Was the person absolutely rude? Am I making sense here? Which is, so I kind of looked at, it's like, well, what do we do that shows respect? Well, we listen, we reflect, we acknowledge the person's perspective. We don't override their position by talking over them. And so, so it's that sense of, so what I did was not really develop my own as much as try and benchmark a little bit what was already present in the literature that could tie to helpful responses. And also could just, and I thought more practical, because again, most of the peers are a Mighty might be more useful, say, with the psychologists folks, but with the peer coaches, I didn't think, and for the enrollment folks who are primarily health technicians, they're not necessarily behavioral health folks. So I don't know if that was
critical.
Oh no,
yeah,
no,
it was
no.
good. And
yeah. So yeah, no, I appreciate the comment, Stephen, because I wrestled with how do we do this fidelity and make it make sense, since this isn't MI research.
I like practical and pragmatic. I love it. So I'm interested in, I'll write you offline to what extent it's can be shared, but seems really, I like pragmatic and practical.
Mhm.
Heather, I guess we're running out of time. Do you want to? I don't know if Heather's still here. You want to do any concluding comments? Because, well, Heather, maybe she's consulting, so thank you for in the middle of a busy workday. I'll just conclude for us, but this was lovely and even brilliant. I hesitate to say it was just a nice integration. I learned a lot, and thank all of you for coming. It'll be posted, and we want to adhere strictly to time limits because I know everybody is off for a busy workday. So thanks for making the time. George, thanks for a lovely presentation.
Hey, thank you for inviting me. I was excited about this. Yeah.
Okay, and nice job. Okay, so we're gonna sign off. I guess I'm
Thanks,
hosting
Stephen.
too. So, okay,
Appreciate your
thanks
time.
for coming. Okay, thanks to all of you. Bye now.